Dr. Surena Namdari is going to be your moderator for this session. We have Andrew Choo from UT Houston, Gabe Horneff, also from Penn, Jack Kazanjian from Lankenau Medical Center, and Rich Yoon from Jersey Center Medical Center. I'll basically turn it over to Surena here to get the session going.
Great. Thanks, Sakib, and thanks to the co-chairs for inviting us to do this. This is a great topic, and I think, we have a diverse panel with diverse training and diverse practices, so I think it'll lead to some nice discussion. So here's some ground rules for our panel. So don't be nice. You don't have to agree with one another on everything. Don't hedge. If you get asked a question, answer that question. And you get what you get and you don't get upset. So if you want a special CT scan cut that is not presented, tough luck. Work with what you got. Jack, you look great, by the way. All right, so let's get into it. So let's start with this one. So we have a 75-year-old female. She has right shoulder pain after a fall. She's had a history of a 4-vessel CABG, AFib. She's diabetic. She's on insulin and Coumadin. She's retired. She's relatively low activity level. And here are X-rays. So, Rich, why don't you tell us what you think?
You may or may not have it, but do you have an A1C on her or not really?
Her diabetes is relatively well controlled. It's under 8.
And she's independent. She
lives alone.
I mean, it looks like a pretty comminuted proximal humerus fracture. I mean, I know it looks kind of smoked, but it looks like the shaft is impacted in the head. It looks like on the most left view, which is, I guess, an attempt at some sort of internal rotation view or something, or maybe an external. Looks like there might be an articular head split as well, but I don't know, that's kind of what I see on the X-rays.
Okay, and any further testing you want on this? Or is this enough for you?
I'd probably get a CT.
Okay.
I'd have friends who would yell at me, but I'd probably get a CT for this.
Okay, so let me show you a few cuts of the CT. So you were spot on. The head is impacted for sure. So you've got this lady now, she's 75, her history, and this is her X-ray. So just, your quick impression of how you're going to approach this treatment-wise.
I mean, for this too, the CT is helpful because it looks like, I mean, the articular surface is definitely out of the socket as well. And it's really a discussion with the family. I've certainly non-opt these with expectations with the family, knowing that, the function might be limited already, but we're avoiding a surgery. But if we are going to go towards surgery, I'm going to recommend the reverse.
Okay. Let me just quickly with the rest of the panel. Jack, what do you think?
I've been surprised at how well patients can do with non-operative treatment in this patient population. So once again, it's a shared discussion with the family in regards to, what her activity level is, what her desires are, and if something were to occur, early versus late reconstruction, the studies have shown that they're fairly comparable for this patient population. So for me, it would be, err towards non-op and let the patients make the decision. But if I were to do anything due to the patient's underlying medical condition, bone quality, I would consider RSA.
Okay, so what I'm hearing from both of you is, non-op is certainly very reasonable in this fracture, despite how bad it looks. But if you're going to operate, RSA is going to be more reliable. Anything different, Andy or Gabe?
No, I would totally agree with what's been said.
Andy Choo can fix anything, so I don't know. Like he literally can fix anything. So I would put it past him.
You can fix it. You can make it look.
I wouldn't try to fix this one, Rich. Thank you, though.
Okay, so we did exactly what you guys said. So shared decision-making, patient really did not want an operation. So we treated her non-surgically. This is her healed. Obviously she has got tremendous deformity. Her X-ray looks terrible. And yet, as has been discussed by Jack and Rich, the function is actually pretty good. You know, she can get her arm up over her head. She's got no pain. She can get to her head and she can rotate. So, you know, a lot of times we look at the X-ray and say, think it's horrible, but a lot of these can do well non-surgically. And that kind of brings us to this study, the PROFER trial, which, you know, many of us know is published in JAMA. There's been follow-up to it that showed really no difference between operative and non-operative treatment of these fractures. So, Gabe, you know, what do you think of this study? Do you think about it when you treat patients? Does it change what you do?
Yeah, I mean, I know a lot of orthopedic surgeons are very hypercritical of this study, and for good reason. You know, there's a lot of questions of, you have a study that's talking about fractures and there's not a single X-ray involved in any of the study, and we don't really know how bad some of these fractures are. But I'd say that I agree with what Jack mentioned earlier. You know, you often get surprised with these fractures. We look at the classification of these and say, oh, that's, you know, a type 3 or a type 4. And, you know, the gut instinct is to say, fix it. But I often take the patient's kind of activity level and their age into consideration with anything that I do with a lot of proximal humerus fractures, and really let it guide. And I've got to admit, I've been surprised, just like we were all surprised by that lady's outcome, where you think it looks terrible and they actually do okay.
Great. Okay. Let's go to a different case. Let's go to why can't you be elderly? So we have a 28-year-old male police officer whose status post a motorcycle crash. No other injuries. He's got some axillary nerve numbness. So, Andy, what do you think?
So this is a high energy, totally different animal. 4-part proximal humerus fracture dislocation. It looks like the head is a separate piece and dislocated posteriorly, maybe inferiorly. It's hard to tell, but certainly would recommend initially more imaging to CT. Okay.
So here's some CT cuts for you. That kind of confirm what you were thinking you would see?
Yeah, I think so. It may not be so much posterior as it is just one of these hypervalgus fractures, but the head is a separate articular fragment as suspected, and it looks not so good.
Okay, and then talk to me about AVN risk. Is this, when you look at this, is this something that you would say is high, low, moderate?
I would put this in the high category. I think somebody once much smarter than me and with a lot more experience than me said that probably the ones that are 4-part, where the humeral head is a completely separate fragment and is anterior and inferior, has an almost 100% rate of complete AVN. And I've taken that to heart, and that's been my experience as well. And so I think those are the ones where I pretty much will say that that's one of the few ones in sort of a younger person would be an indication for a hemi for me, even if I think it's technically fixable. I have found that the ones that are more posterior or hinged actually don't necessarily have the same risk, but in a 28-year-old, I'm probably going to say that this is extremely high risk for AVN, but we're going to give it a chance because you're 28.
Okay, so, you know, the other thing I'd like to just bring up is this hurdle study, which I think a lot of us know and look at. It talks about that medial hinge being intact versus not intact, and then the spike of bone on the calcar being, you know, greater than 8 millimeters or less than 8 millimeters. And so, you know, clearly this patient has both factors for AVN, but at 28, you know, you may not have many other options. Here's another couple cuts of the CT. So tell me how you would approach this surgically.
Can I just bring up a little
yeah, please.
An editorial? I think that we've talked about this with Rich as well. So that, you know, that hurdle study, everybody quotes that hurdle study and the residents get tested on it all the time, which I think is unfortunate because that's a study for intraoperative blood flow. And they tested that with drilling the head. And that same study that everybody quotes for AVN risk, you know, Hurdle published his follow-up 4 years later and basically said that the intraoperative ischemia did not correlate with late AVN. And so he kind of recommended fix what you can. And I think we're still in the position of not necessarily knowing who's going to get AVN and how bad it's going to be.
Yeah, I think that's a great point.
So were you asking me about what I would do with this?
Yeah. So how would you approach this? Are you plate and screws, nail? Are you having a hemi available, or delta pec, deltoid split? What's your go-to?
So I would say that for this, for me, my own preference would be, again, I think I'm going to fix this, but not even probably going to have a hemi in the room because I'm going to give every attempt to try to fix this. because of the patient's age, understanding that the risks are still involved with pretty high risk of AVN and other complications. I think I would personally do a deltoid split on this. And I think that's probably goes against what most people would say, but I would do a deltoid split in a 4-part. You can move the tuberosities out of the way and you're looking at the cancella surface of the humeral head. I would try to rotate that. A lot of different things to try to get it aligned appropriately with the head shaft angle. You could try pinning it to the glenoid provisionally and then sort of closing the book around it. But this would be a long case. I would pretty much have every trick I know how to use, try to get this to look like a proximal humerus again.
Great. Anybody else? Jack, you going deltoid split, delta pec?
I know our trauma compatriots like do the deltoid split, but they don't think about the late, arthroplasty. So when they bag the axillary nerve, it's very nice to have someone that you can't do an RSA on later on down the road. But I'm a deltopectoral type approach individual. I find that these are hard enough to reduce from the front rather than from laterally. I've never been very good at reducing the neck shaft angle from a lateral approach. But I'm more of a deltopectoral approach, and I would do everything I could to reconstruct this. And I would have a hemi available, but I would also have other biologics, such as a fibular strut, angle a little bit differently than normal in this patient population. However, I have been pleasantly surprised to know in these younger patients that even though the hinge is disrupted, sometimes you can get that head back on, and it's not as unstable as you think in some of the older patients, such as in the mid-50s. To make it look like a proximal humerus again, but I'd have a strut available.
Okay, Rich, Jack says that Andy's crazy doing a deltoid split. He's going to get the nerve. Do you agree with him?
I don't know. I thought Andy did a shoulder fellowship at Rothman, so
He did.
I don't really. I think I could go either or. I think I'm more comfortable doing a pec, delta pec, just because if I need to come back and do a reverse, I'm not as comfortable doing it through a deltoid split, but I can certainly do both. If with such a high risk of AVN, I'm going through a deltopec. I do agree with Jack. I probably have a fibular strut in the room just in case. And I feel like a key to these too is when you start getting after this, if you don't pay attention to how much stripping you're doing, you can leave some of these soft tissue, the bony structures rather bare. And I think that's a mistake too. I think that you have to be kind of conscious of using whatever is attached left to help you get and maintain the reduction, especially around the tuberosities. And for me, I'm probably, just like Andy said, pinning the head to the glenoid, fixing the tuberosities, getting my proximal fragment first, and then bringing everything down to the shaft to kind of help that neck shaft angle. But yeah, for me, it's going to be a deltoid split. Deltoid pec, sorry.
The one thing I'll add for this, when you're worried about AVN, what I'll do is I'll make sure that my plate's in a proper place where I can get a lot of inferior screws and long calcar screws. And I'll leave my superolateral and superior screws a little shorter, because when they do get AVN, it's more superior. And as long as you don't have penetrance of your screws, you'd be pleasantly surprised at how well patients can do with AVN in this circumstance, as long as they're not grinding their screws into the glenoid. So that's what I'll do for this type of patient population also.
Great. Gabe, let's hear your vote. Delta pec, deltoid split.
I would do delta pec for this. I think for all the reasons that were mentioned before, also my comfort level. Everybody's talking about fibular strut having it in the room. I probably would do the same, although when you see these kind of fractures and AVNs on your mind and you think about what potentially could be the next step, obviously we all hate when the fibular strut is in the canal and then, we're cursing that it's there because we have to try to figure out how to get around it. So I would just be prepared for that for my next step. But I probably would try my best to use some other sort of bone graft to try to fill in any voids that I could and try to really hold off on the fibular strut unless I just can't get it to seem to sit in a good place.
Right. So, obviously the thing that I think you guys have all touched on is you have to be able to reduce this anatomically. That's been shown over and over again as the probably number one predictor of failure is anatomic reduction.
I love that tattoo on your shoulder, Surena.
Yeah, sometimes you think things look better than they really are, Jack. That's the point of that. So, you look at this study, which is really interesting. 98 patients, they only the rate of anatomical or acceptable fracture reduction was only 40%. So, I mean, it just goes to what we already know, which is these are really hard. These are hard to get right. And the complication rate was high because they obviously had a low rate of anatomic reductions. So, reduction quality was directly correlated to clinical result. And then, Jack, you also brought up the Calcar screws. This is the study that started this whole mania about Calcar screws by Mike Gardner. And so, they basically showed that without the Calcar screw, they had higher rates of failure. Eric Patagimis, who was a resident with us a few years ago, who then did a shoulder fellowship with us, defined the Calcar as being within 12 millimeters of that inferior margin. So, for this case, I did a deltoid split, which I used to do more of. I actually don't do it anymore. I've gone away from it, but this was a few years ago. And I thought that it was going to be easier to get the reduction through a deltoid split. And I think there's no doubt about that. I think some of the other issues that Jack brought up with the nerve and maybe scarring for later revision surgery are good points, which is why I've gone away from it. But it definitely makes the surgery easier. And this is Mike Gardner's approach. But basically push the head back out of valgus, realign it with the shaft, and then you have a defect. Fill that defect with cancellous, and then here's our intraoperative reduction. And there you can see the nerve, which is draped over the plate. So and then sutures into the cuff. So
looks great.
Yeah, and so I think the point about deltoid pec versus deltoid split is interesting. This is a recent study that randomized patients in Canada to deltoid pec versus deltoid split, and interestingly, they actually did find a difference. They found poorer functional results in the deltoid split group, and so many of the authors went away from the deltoid split approach, and I have too. But I think it's a good thing to have in your back pocket because some cases, this guy was really muscular, and it would have been really, really hard, I think, for me to do it through a delta pec. And there's our final kind of intraop fluoro. I agree with Jack. I do the same thing, keeping those superior screws short just in case they develop AVN. And that's kind of our result at 6 months. Any comments from the panel?
Looks outstanding. Your arch is reconstructed. Your tuberosity head height is perfect. It looks fantastic.
It just goes to show, just like what Andy brought up before, hurdles or initial study, you just got to keep an eye on, I feel like we got to give these more of a chance than, we're taught to do initially, but it looks great.
Did you hold him for 6 weeks post-op due to the combination of his tuberosity and instability of his head fragment, or did you move him post-op typically like you do for a shoulder fracture?
I started gentle passive external rotation and elevation at 2 weeks. I thought we had pretty good fixation, but as you can see, his tuberosity has gone on to resorb. His head is still looks okay and viable. That was at 14 months. He's now about 3 or 4 years out. I see him every year, and he's doing fine. He still has maintained overhead elevation. He has some external rotation weakness, but is living with this for now.
I think that shows another reason why I'd be so hesitant to do a hemi on him. If you looked at his initial films, he had a fair amount of comminution of that greater tuberosity, and obviously we know if that doesn't work, it's a bigger deal. I don't know if it would necessarily have had a great outcome if you were trying to get that tuberosity healed down to metal. So I applaud you on that.
Great. All right. Well, let's go to a different case. So a little different animal. So now we're back into the more elderly population. So 76-year-old male, he fell. He's about 4 weeks out when he comes to see you. He lives alone. He's, relatively healthy enough for an operation. So Gabe, what do you think?
So this is obviously a fracture that I don't think is going to probably do well non-op. But yeah, that articular surface of the humeral head is almost completely facing south and basically adjacent to the humeral shaft. And so I think he's probably going to have a hard time trying to heal this into any sort of function. The greater tuberosity is way up. I probably would get a CT just to see how much of the greater tuberosity is sort of by itself versus as part of that humeral head component. I guess you got that here. Yeah, so I think for this guy, I probably would try to fix it. I would feel you've got a fair amount of bone stock left to the head, and should be able to get a good result. And this is probably one I would try to use a fibular strut if I was having any issues. I'm less concerned about AVN on this guy, and then, you know, prep him for the possibility that if it doesn't work, you know, have a reverse available.
Okay. And anything special you're thinking about 4 weeks later? Is there challenges that you may not have early on?
For sure.
Is there a limit? Is there a limit where suddenly you say, okay, it's been 8 weeks, 6 weeks, you know, fixing this isn't going to work anymore?
I say probably around the 6 week mark, although there's no doubt in my mind that, and I tell patients this all the time, that even though you can't see any callus formation necessarily on the X-ray, there's no doubt in my mind that there's probably some sort of healing going on in there. And it's, you know, going to have to be something that's going to have to be mobilized. And they always say, you're going to re-break my bone. And I kind of explain them it's a little more delicate than that. But yeah, I think that's definitely a concern. The good news is I don't see anything too badly medialized. So one of the things you worry about with this, and I had this happen to me once, is when it gets a little bit later, you start to mobilize these things, you worry about the circumflex vessels perhaps being tethered in there. The case that I had where that was a problem was the woman's shaft was medialized fairly significantly to the head. I feel pretty confident, at least on these X-rays, that that's not so much of the case. So definitely want to be prepared for that and take your time when you're starting to mobilize everything.
Great. Okay. So it sounds like you're planning to fix it, maybe with a fibula strut. Anybody on the panel thinking differently about this case?
I would ask, what's the patient's function?
So he's got no function. He can't raise his arm.
No, prior to his fall,
normal.
How active was he? Does he sit and watch the Phil's game with a 6-pack of beer and a carton of smokes, or is he fairly active where he's out in the yard and working?
No, you know, he's not super active, but he takes care of himself. He lives alone. He's not involved in any athletics. So he's a low activity guy, but he lives alone and takes care of himself.
I think, you know, he's going towards surgical intervention. And with this fracture, which is a 2-part, I think you can fix this, at least for me, 2 different ways. If he's, you know, elderly, lower active, and there's not a lot of comminution along the neck or comminution along the greater tuberosity, you can consider suture fixation or valgus impaction suture fixation, the parachute technique, versus valgus impaction plating, rather than trying to get it perfect with a strut and so on and so forth. You'd be surprised at how well patients can do with making this a 1-part, as John Fenlon talked about in the past with suture fixation, and or just impacting the shaft into the head, putting it into valgus, and using a plate where the shaft actually works like a strut. Then you don't have as much issues with the strut down the road if necessary. So just from a technical standpoint, if the patient's, you know, low activity level, 2-part fracture, and not a lot of comminution along the neck, you can consider suture fixation with parachute versus what I would use as a valgus impaction plate instead of using a strut.
Rich, any role for a nail?
No.
No nail. How about Andy? Any role for a nail?
No.
Not in my hands. I don't think it's unreasonable to use as an implant, certainly. I think it would be an open nailing where you'd have to get your reduction first, clearly. But, you know, I think if you get your reduction, the nail as an implant is also perfectly acceptable. And it can potentially substitute for your you know, the fibular strut to some degree.
Okay, so Andy, would you use a fibular strut here, you think?
I think I most likely would. I think, you know, just go back to the initial thing. It's always a warning sign when somebody shows up 4 weeks later. You wonder why they showed up 4 weeks later. So I would still, you know, I think non-op is still on the table depending on discussions with this guy. But if he's otherwise, you know, normal, healthy, one thing I always talk to these people about is how much of your life is lived overhead. Because frankly, I think if he healed right here, his waist level function would still be fine. But if I'm doing surgery, it's going to be probably fibular strut, plate, try to get this anatomic.
And just talk to me about the technical part of using a fibula strut. So where are you putting it? How long is it? And how are you using it?
I could give you a 20-minute answer. I won't, but
no, give me like a 30-second answer.
The 30-second answer is it depends on the fracture. And so for this kind of fracture, the fibula strut is going to be fairly central. They try to medialize it a little bit to just try to prevent this recurrence of the varus deformity. but it's going to be pretty central. If you do a deltoid split, then it's, you have to deliver the shaft laterally. If you're doing a deltopec, then you deliver it anteriorly, like you're doing a total shoulder. But sutures in the cuff, mobilize the cuff, accentuate the varus deformity, pot the fibula, and then reduce the head over it. That's essentially, and then use your plate to try to medialize the fibula with the push screws, as Gardner's described as well.
Right. So what we did was use a fibula. I didn't use a nail. I didn't want Rich to vomit. He looked kind of queasy there when I brought it up. So, got our reduction, and like Andy said, tried to make the fibula replicate the calcar, hinged it off of the lateral cortex, and then potted it medially into the inferior part of the humeral head. And there's our reduction. And so far, he's doing well. But, the data on fibulas is actually, really impressive. The studies that are out there show very low rates of failure in terms of fixation failure or loss of reduction. Now, the question becomes, what happens if somebody like this gets AVN and needs an arthroplasty? And certainly, many of us have struggled with dealing with fibulas and arthroplasty. But I think if you keep it small, relatively speaking, you can ream through it with you buy a tenodesis tray or a cannulated screw set under fluoro. So, and plus with 2 parts, it seems like, AVN is far less of an issue. Any comments on this? Anything anybody would have done differently?
How much callus did you find in there? We talked about that at the beginning.
Yeah, I got to him about 5 weeks, so he was pretty scarred together. There was no real bony healing. It was mostly that, impending non-union scar that you see, that thick scar.
Hey, Surena, this is Derek.
Yeah.
Sorry to jump in real quick. I think this is a nice question in the chat. Question is, so when do we go for more anatomic reduction versus a quote unquote non-anatomic reduction in elderly fractures, such as like valgus impaction, as Dr. Kazanjian just mentioned?
Great. Jack, so why don't you answer that? When do you go to a non-anatomic, potting it into valgus, either with a plate or with suture, whatever you want to use? What is it about the patient that makes you make that decision?
Elderly, lower activity level, shoulder level function and below is all they really need. Not significant high level function overhead. Physiologically much older, or physiologically older. And when they're younger, physiologically or numerically, then I go for anatomic reduction. That's basically my indication.
Great. Yeah, I couldn't agree with that more.
And I use sutures. I've seen some of the chat. I use sutures with hardware, without hardware, into the tuberosities, into the cuff, into the interval, into the shaft as an augment, as a reduction tool, as an augmentation reduction tool. I use it all the time. It's paramount to any internal fixation that I do in proximal humeruses.
Yeah. Okay. Great. Yeah, I've seen you suture the frontal lobe to the plate.
I suture my own frontal lobe. It's wonderful.
Okay. All right. Let's go to this case. A 70-year-old male, retired oral surgeon. He falls down the stairs. He's got a T12 burst fracture that's also being treated non-surgically. Jack, what do you see here?
So my only question is this one of those?
It's not a question. It's what do you see here?
I see what looks to be a unstable 4-part fracture, possibly 4-part unstable valgus impacted. The head seems to be hinged posteriorly. I see a lesser tuberosity fragment anteriorly and a large greater tuberosity fragment with possibly some articular surface attached superiorly.
Okay, and what was your question? I'll do my best.
No, that's just, my question is it a true 4-part or is it one of those unstable 4-part valgus impact?
Got it. Anything else anybody sees here that's concerning?
How's the glenoid?
He's got a scapular fracture.
Yeah.
He's got a scapular neck fracture and some angulation of the scapula. Whether or not it goes intra-articular is another story. But I mean, if you look at the axillary the glenoid looks in appropriate position.
Yeah. Okay, so you got a 70-year-old with a, maybe 4-part, either way, comminuted impacted fracture and a scapular body fracture. I'm assuming all of you want a CT scan, so before you ask for it, there it is. And so what are you doing with this, Jack?
Pretty active. I mean, he just recently retired, pretty active.
Yeah, he's pretty active guy. He's fit, he's, healthy, no other real issues here.
I mean, you would be surprised with this type of fracture that you can fix it, and they may do fairly well with fixation. I don't think you have to go. I tend to push the envelope with internal fixation, looking at physiologic age, especially in the face of a scapular body, neck fracture. I think this is an intraoperative decision. I'd go to fix it. I probably would steer this person towards fixation unless they have some other comorbidities with the trauma that are preventing him from undergoing immediate internal fixation or surgical intervention. And I would look towards anatomic reconstruction, but have an RSA in the room.
Okay, so Jack's planning to fix this. Gabe, you agree?
Yeah, I mean, if you look at it with the exception of the scapular fracture, this isn't too dissimilar from one of the ones you showed earlier. And with the difference that this patient's obviously a lot older, but I think it's reasonable to try to fix it. But I probably would have a much lower threshold to do some sort of arthroplasty if I got in there and it just started to fall apart because of bone quality.
Okay, Andy, fix, replace. Andy?
He's on
Sorry.
mute.
So I can't believe I found somebody who's more aggressive about fixing than me, because I would say that this one, I've had bad experience trying to fix these in terms of AVN risk when these hypervalgus sort of 4-part fractures. And I've had a few that I fixed and look really good initially, and then they've gone on to AVN. So I would have a low threshold here. I would probably just do a reverse on here, and the question would just be, scrutinizing the CT carefully to make sure that the scapular fracture doesn't compromise any of the implants.
Rich, you agree?
Yeah, I agree. I think that in my hands, I'd probably bring it up to the patient, but the reverse trays would be open and not the fixing stuff. The only question to me would be how hypermobile the scapula is. So if it's really too hypermobile, where I feel like I couldn't get a reliable pin placement in the glenoid, which shouldn't be that bad because of all the muscle attachments in the scapular body. Especially since I'm doing this beach share, it should kind of help stabilize it. I'm probably going to go to reverse almost right away.
So that's what I wanted to ask you guys about. So let's say you're going towards a reverse in this case. You have the scapula fracture. Is it something that you're going to delay the reverse at all in order to let that start to heal? Would you ever fix the scapula in conjunction with it to stabilize it? Or is that something that you're deciding intraoperatively? If the scapula starts to tilt, then maybe you'll fix it then. Rich, what do you think?
Before I prep and drape, I'd probably be ready to do both. If I put my hand on the body and the inferior angle of where the fracture is, and I try to kind of like manipulate the shoulder. If I feel a lot of motion at the body, then I'm probably gonna, go lateral on a beanbag, fix a scapula first, then go beach share, then do the reverse. If there's not a lot of movement with forward elevation and rotation of the scapular body, then I'm probably just gonna go to reverse off the bat.
Andy, any other tips that?
I think I would really, really want to know beforehand what I was going to be doing, because those are two very different operations for me. I think that if
I'm the aggressive one.
But I think most likely I would be leaving the scapula alone. Just if it's purely extra, if it's extra-articular, it's just in the body, I would probably be leaving that alone. Or if I was planning on doing it, I'd probably stage the two, maybe fix the scapula first and then at a different setting, go back and do the reverse.
Okay, great. And Gabe, let's say you're doing a reverse here. It starts to fall apart. You try to fix it for, 20, 30 minutes. It's not working out. Two things that commonly come up with reverse. One is, how do you get the height of your stem and make sure that that's right in a 4-part fracture?
Yeah, so I mean, you can use, even though it's based on the hemi, you can kind of use the pec insertion to sort of guide you. I find that more often than not, I end up seating the medial aspect of that implant almost right up to whatever calcar is still left on the shaft, just for stability. But the other thing you can do is if you have some sutures in that greater tuberosity fragment, you could bring it around and get a sense of where your height is and almost make it look like it was, you know, as you would make a cut initially for a cuff tear arthropathy patient. So I think a lot of it is sort of a feel. And if you want, you can have intra-op C-arm. I don't typically do that when I'm doing reverse, but if you were initially going to plan to fix this, then you would probably have it in the room. So you could always judge it that way.
Yeah, I mean, I agree with you. I think it's all about what's left of the calcar. And if there's calcar attached to the head, you can measure how much is left on the head and then cement proud, depending on what that measurement is. If there's no calcar attached to the head, you can just pot it right at that medial aspect like you talked about. And then Jack, how do you get the tuberosity perfect on a reverse? Commonly you see X-rays where the tuberosity is either distalized or it's over-reduced medially. How do you prevent that?
I think, you know, at least when I've done reverses as opposed to hemis, as long as you put the stem in properly, you mobilize your tuberosities properly, you'd be amazed at how well the tuberosities kind of come back almost anatomically compared to hemi. I don't use the superior border of the pec. For me, I do use intraoperative fluoro. I use the same tuberosity fixation techniques as I do for hemiarthroplasty as described by Boileau. So for me, it's once again, if the calcar is intact, I put the stem, the medial portion of the stem, maybe just a little bit above the calcar. That sets my height. And then typically the tuberosities can kind of go where they need to be from a tension perspective if your humeral implant is set where it needs to be with the proper version. And you'll always see a little fracture line that you can, with your sutures and a large point of reduction forceps, bring your tuberosity back to where it needs to be and be clamped. So for me, it's more about if you put your stem properly with proper version, the tuberosities seem to just kind of sit where they need to be with a little bit of abduction and external rotation. And I do use intraoperative fluoro.
I have a question for the other guys on the panel. Suture configuration to repair this. So when I first started doing these with a reverse, I used to put those drill holes in the top of the shaft and then try to get sutures coming down. But I often found that sort of over-reduced my tuberosities and I didn't really like the way it looked. Just curious what the other guys do for suture management when you're repairing the tuberosities for a fracture to a reverse.
So Gabe, I've had the same issue and I've actually had those bone tunnels cut out, like when I'm trying to bring it up because the bone's so bad.
Yeah.
I've gone to using a on the shaft prior to reaming, putting a all suture cerclage with the fiber tape around there, but I don't cut the limbs and I leave the fiber tape long. And then those are in lieu of the bone tunnels. I've been using that to get my kind of vertical tuberosity control by kind of crisscrossing them after I get the tuberosities together.
Gotcha.
And that's been in those cases, that's been pretty reliable to prevent a tuberosity escape.
I think it's also when you tie them. You know, I tie my horizontal stitches first, and then I tie one vertical stitch, just like a flyaway stitch, and I don't tie it very tight. And that kind of leaves it where I put it. But you know, you guys, I don't think need this 3D CT. But there's our result. I waited a little bit on him. I waited about 3 or 4 weeks. I let the scapula get a little bit stickier because I was worried a little bit that it might tilt my base plate. And
did you use a small shell on him?
Yeah, that's a small shell.
Okay.
Yeah, he went on to heal, and he did fine. And you know, I think that discussion between reverse versus fixation in these more elderly fractures is an interesting one. And there is some recent data. This is a randomized controlled trial, JBJS 2020, where they took patients who were what they considered elderly, 65 to 85, and they randomized them. And you know, the constant scores were better in the reverse group, so it seemed like it was a more reliable result. Now, are there patients in this age group that you'll still fix? Certainly, but I think you can feel confident going to a reverse for a lot of these people.
And I see you uncemented, you press fit a stem.
Yeah, that's not common for me. I usually
pretty gutsy. I find that for fractures, even in males, that the canal is fairly capacious, and to get a press fit in there is difficult. There's a lot of rotational instability. I find that to be a totally different animal. So I still cement all my stems. It also allows me to help with if there's calcar involvement, if there's height issues. So just question on how often do you uncement versus cement your stem?
Yeah, I almost always cement. So maybe 10% of the time I can get away without cementing it, and I take the bone from the head and impaction graft around the medial or the proximal part of the stem, and that works out. But most often, I think your point's really good. I usually cement these.
Question for the panel too. When you guys dial in your stem version, where is everyone kind of putting their stem? I've always been taught 30. I've heard recently, going back to early Grammont papers, some folks are dialing it back to 20. I guess where do you guys put your stem version?
I go to 30. The only patient that I can say that I didn't do that was somebody who had a contralateral reverse. And so I wanted to make sure they could have at least one hand that got a little bit more behind them and one that got a little bit more in front of them. So I put it a little bit more retroverted than that, but typically 30 to 40 is where I keep it.
Jack, number?
Typically, 20 to 30. I think some are implant based, but I think, at least the implant that I've used, old school, keep the fin a little bit posterior to the bicipital groove, allows you to keep the version where it needs to be. And also basically just, when you put the medial portion of your stem on the calcar, it's going to rotationally sit where it needs to be. And for me, it's around 20 to 30.
Andy, anything different?
It's usually, I do maybe a little bit less retroversion just for the tuberosity, for to benefit the greater tuberosity, but usually about 20, 25.
Yeah, I'm around 10 to 20.
Can I just add one more thing about,
please.
I think this is mainly, you were talking about tuberosity position, and a lot of the things we're talking about, maybe because I'm primarily a trauma guy, is that I use a lot of floor, and I use floor during these cases. And the two main places I use it for reverse refracture is when I have my pin in the glenoid, just to make sure I like the position of it. And then number two is when I'm tying my tuberosity down, to get my greater tuberosity position exactly where I wanted to dial it in, I put graft underneath it if it looks like it's being over reduced and it needs a little bit more, to be offset a little bit more. So it's certainly not wrong. And it's I know that if your practice is primarily elective and you're never using a C-arm just for shoulder arthroplasty, I think it can actually be very helpful in these cases.
So two quick questions and two quick polls for the crew. Who repairs the tuberosity? Number one, the lesser tuberosity with their fractures, number one. And two, do you do a partial release of the supraspinatus off the GT when doing these fractures?
Okay, so let's see hands. So who repairs the lesser? Okay, so just about everybody repairs lesser. Who releases some of the supraspinatus?
And
Jack, sometimes Gabe. Okay.
The interesting thing is, though, I'd be curious. I mean, I always repair the lesser and the fractures, but when I do a primary for cuff tear arthropathy, if they have an intact subscap, I often, with the implant I use, don't repair it. I'm just curious what other people do. Do they always repair the subscap if it's intact, if they're doing a reverse for something else?
So I'll just, in the interest of time, I'll just comment. I think, the data is mixed. I don't think there's perfect data to guide us. I only fix it I think you can do either one. I only fix it for one reason. I think if I ever have to come back, it's easier for me to find the axillary nerve if there's tissue under tension in the front of the shoulder. So that's the only reason why I fix it. Okay, let's try to get at least one more case in. So we got this 56-year-old female. She fell. She's otherwise healthy. She comes in 10 days out from the injury, and here are her X-rays. So Jack, what do you think?
The
op, non-op.
The only thing that bothers me, there's one thing I'd like to see is how much comminution along the inferior neck calcar there is. On the AP, you see there might be some comminution there, which may portend more instability. And the only thing that, well, the two things that would direct me are, one, the amount of varus, and how high that greater tuberosity is, and the fact that she's young. The sagittal alignment is excellent. The axillary alignment's excellent. She's young, and she's, got a significant amount of varus with maybe some comminution along the neck region, which could make her tip into more varus and be unhappy. Varus malunions tend to be, in younger patients, don't have a lot of great options, and patients are fairly unhappy. So I would get a CT to see if there's how much comminution there. I'd have a long discussion with this patient.
Okay, so I don't have a CT. You get what you get. You're gonna fix it or watch it?
I'll talk to the patient. Go, what do you want? Do you want to give yourself the best chance of function? Because I could fix you and you may still get stiff and not be happy, or I could leave you, and if you're unhappy, our
Stop
options
hedging.
are a lot.
What would you do, Doc? Doc, I'll do what you say. What would you do?
This lady, I'd fix it.
Okay, Gabe, fix or watch?
I would probably initially follow her very closely with weekly X-rays, and if it started to show any more motion, then go to fix and have a short fuse to do that.
Okay, Andy, fix, watch.
I would agree with Gabe. I'd watch this initially.
Okay, Rich, anything different?
I'd offer fixing it, but if she wants to watch it, I'd watch it. But I'd recommend fixing it.
Okay, so we watched it. She really, I mean, her pain was out of proportion to her exam. She made me nervous operating on her, and I thought, the deformity didn't look horrible to me, so I thought we'd watch it closely. So there she is at 3 weeks. So anybody changing their plan based on these X-rays, or
that's not looking bad. That's a better AP. It actually looks pretty good.
okay? So you're okay watching it still then?
I mean, you're at 3 weeks now.
Yeah.
Yeah, might as well just watch it.
Yeah, you're 3
Okay.
weeks.
Okay, so
Whether or
now
not she hinges open laterally, doesn't heal is another story. But if she
well,
goes out, then you fix her later.
she's doing okay. She's now 6 weeks. She started some therapy. She's really stiff. She doesn't have very good range of motion, but here are her X-rays. Anybody changing course now? Okay, nobody.
Not changing course, but it's not looking very good.
Yeah.
Okay. When do you see her next, Gabe?
I'm probably seeing her 2 weeks after this, to be honest with you, with the way the X-rays.
Okay. So that may have been my mistake. So I saw her at 10 weeks after. And so now what do you think? She's got, her motion's really not good. She can get her arm maybe to 50 or 60 degrees. And abduction, she's got maybe 20. Mostly
She's not
scapular.
healing. She's windshield wiping. That tuberosity's high. This needs to be fixed.
Yeah,
I feel like at 10 weeks, at the very least, you normally start to see that lateral callus forming, and she's not making any of that.
Yeah.
Okay, so everybody thinks this is kind of a impending non-union with varus displacement?
Yep.
Okay, so if you look at her CAT scan, you'll actually see that she looks pretty much healed.
She a smoker?
No.
And
Looks
then
like smoking bone.
you think she's healed with that cavitary appearance?
I can tell you with 100% certainty that she is healed.
Okay.
So now what?
How's she doing?
Crummy. She's
Okay.
got bad motion. She hurts. She's
Does
not
she have
happy.
secondary gain?
No secondary
All
gain.
your patients do.
No,
I'm guessing you went back in
One of
and
she's
you weren't
one
happy
of the
that she
few
was
that
here.
does not. And no, she's. I mean, she's just unhappy. She's asking me why this is not going well. So now what? I probably should have listened to you in the beginning, Jack, and fixed her.
Yes, I'll mark this down as a date in history.
Yeah, but remember, you flip-flopped at the end. You went back to non-op when you saw the
I
second
basically
X.
I said non-op later on. If
Yeah,
you already bought
remember, we're recording this
it, might as
session.
well ride it out. I closed the deal. I ride it all the way out. So
Yeah, you got to operate on a lot of these to find one that you save. All right, so what are people doing now? Andy.
Getting out the tracing paper. I'm planning for valgus osteotomy fixation.
Okay, everybody agree with that?
Yeah, if she's doing crummy. Gotta do something.
And Surena, is crummy pretty much just, I guess, abduction is really her biggest issue?
Abduction, forward flexion. She's limited in external rotation too. Her motion really is bad globally, and she hurts.
Yeah, these varus malunions in younger patients, they don't do well. And I think the only option truly is, when they're this bad, is osteotomy.
So there's a good question in the chat asking, does somebody have a number for the amount of varus? I don't. I feel like it's really a judgment call on how close that tuberosity is to the undersurface of the acromion, and really kind of see how they're doing functionally. I've had ones that, kind of look like this, and they're pretty happy. They might, if anything, they limit some abduction, but their forward elevation somehow is still good, and down low, their rotation is fine.
If the patient is happy and they didn't want surgical intervention and they're tolerating it, then there's no number for me either. I treat the patient, not the X-ray.
That's what I wish the Proffer study did, right? Like, I feel like we all do that. I feel like that's what I wish the Proffer study did was, okay, crappy X-ray, who did well regardless, and they they just didn't do that, because I feel like all of us who treat this are along the same aspect. It doesn't matter what the X-ray looks like. If they're doing fine, they're doing fine. If they're not, then you got to go in.
Yeah.
And I think that, Gabe, that question's really good. We looked at that in the lab with Mike Hast, and it looks like not only is the displacement of the tuberosity important in terms of impingement on the acromion, but the shape and the morphology of the acromion really has a lot to do with when you get bony contact.
I think a lot has to do with how much scapulothoracic motion they can compensate with too.
Yeah, I think that's right. So, we had this varus deformity. That's our planned osteotomy in a crude way. We brought the head back. You end up with this void of bone laterally. So we filled that void with cancellous graft, and there's our plate and screw construct. So any comments, anything anybody would do differently in terms of fixation?
These cases, the struts helped me a lot for that lateral side. So I think it looks great. I'm pretty terrible with like the void filler stuff. So this is where like a nice strut will help fill that void and get some extra fixation for me. But I think it looks great.
Great. Any other comments on it?
How did she
do better
in the long run?
Yeah, she did great. She, she was able to progress in therapy. She wasn't, she stopped with her. She had plateaued before. She was able to make progress. So ultimately, she shook out at about 140 degrees of elevation, maybe 120 of abduction. So, she was very happy.
Surena, I think you kind of gave a pretty accurate. I can kind of envision her in my office. And I feel like these patients who initially will like almost force you to non-op, and then you kind of just like sit there and you're like, okay, we'll see what happens. And they'll, they show up in the office when they're like, I can't take it anymore, right? And then you're like a superhero. So I feel like, listen to the patient initially, just like Jack alluded to, is important. Make that decision, and they'll come let you know if they need surgery or not.
Great. So we have about 9 minutes. I want to go through this one last case relatively quickly, but it's my cathartic disaster situation. So 82-year-old female. I think many of you can relate to this patient. I'm sure this person has been in your offices. So 82-year-old female, she trips and falls 2 days prior to coming to see me. She's got frequent falls per her family. She's a medical, disaster, cardiac disease, AICD, longtime alcoholic. She's a smoker still at 82, half pack per day. She lives in assisted living. She's incredibly cachectic. BMI is 19. And this is her X-ray. So, I think no doubt about it, I don't even have to ask the panel. I know you're all treating this non-operatively. So, our plan was non-op treatment, sling, follow-up in 2 weeks for repeat X-rays. And so, exactly what you think would happen happened. And so she has 2 falls in 2 weeks. And so now you have this. So, Rich, anything here? Anything you're going to do? Are you going to operate on this person now?
So I always go back to this this patient I saw in Nirmala Tejwani's office when I was in R4. She was like 93, same profile, right? New Yorker, pack like smoke, wearing her Jimmy Choos, smoking 2 packs a day. So I see the pre-op, and it was a pre-op X-ray. I see the X-rays in his office, and she's got dislocated shoulders bilaterally. So I'm all pumped up. I'm like, Tej, we're gonna book a reverse. This is gonna be awesome. Blah blah blah. He goes, okay, go see her. And I walk in the room, and I'm like, oh, how are you doing, man? And she goes, she's great. I'm doing great. And her humeral head is in her chest wall, and I'll never forget that, because the slide you showed before the X-rays, I got to be honest with you, I'm not touching this lady with a 100-foot pole with a knife. Even if it looks like this, I'm letting it fly. Because after seeing that, I'm like, I can do more harm than good. And for me, I'm telling the family, like, I don't care how bad the X-rays look. You know, I can certainly make her worse, you know, the infection rate and all this stuff. Because at this point too, I'm thinking about a reverse, not necessarily fix. But for me, I'm keeping this in a sling.
Just get her a longer cigarette.
All right, so Rich isn't touching it ever. Andy, you agree?
I agree. I think this is, you know, when you have a translation complete 100% with the shaft and the head, that's usually a poor sign for function and for non-operative treatment. But this lady, if she's fallen twice already, unless you're going to cure that, unless you're going to cure the rest of her comorbidities, I'm not touching it.
Okay, great. So our plan was the same. No way I was going to touch this. So continue non-op sling, follow up in 2 weeks. Unfortunately, now you get a call where she's developed a wound on the front of her arm, and her PCP put a dry dressing on it and put her on antibiotics. And she comes in to the hospital, actually. And so now she's got this. So what do you think, Jack?
Well, now your hand is forced. So I would do what I talked about before, which is, even though it's kind of got a little bit of shear component to it, I would take her to the operating room. You might even want to, if you want to stage it, you know, take her, you know, wash her out the first time, bring her back, you know, if she's medically stable enough to undergo a second operation. But I would do suture fixation of this, valgus impaction, suture fixation. I wouldn't put any hardware on this lady.
Gabe, do we have to operate on this? Can you close reduce it and, I don't know, put her in a spica and put a dressing on this?
No, I mean, you're going to have to at least wash it out and do your due diligence. I mean, the question becomes, you know, can you keep that shaft kind of in a better position? I agree with Jack. I don't want to put hardware in this, maybe suture fixation, maybe some sort of resection arthroplasty at this point. But yeah, you've got to do something. You can't ignore this.
So that's a good point. So if you do a resection here, how are you going to
control
control
the
the
resection
shaft?
with this?
I'm not saying like it's probably very tough to do, because she's
you'd have to shorten her arm and then put fixation into the glenoid to the lateral shaft, and she's going to drift. Even if you drape the pec over it, she's probably going to drift anteriorly. So it's not like you're doing resection for someone with you know, an intact proximal humerus. Great idea, but I don't think it's possible, and I think she'll drift even more and still have wound issues anteriorly.
Andy, suture fixation, anything different?
Yeah, I totally agree. I think if she's healed, then I have had this in the humerus more distally, where I've just taken up and shaved the bone down, essentially gotten rid of the offending protrusion. But if she's not healed and still mobile, then I would do exactly what Jack said: just parachute, impale the head onto the shaft.
Yeah, try and get it impacted up there.
Yeah. Okay. So, you know, that's what we did. We did the parachute technique that Jack brought up earlier, so described by John Fenlon. And so, you know, you can take heavy Dacron sutures, you can pass them through the tuberosity, through the cuff, and then into the shaft. And it basically impacts the head into the shaft, just like Jack said. So you can see the head is in valgus, and that's what we got. And so, you know, pretty happy with that. A lot of bony contact. I think it looked okay.
Do you do this technique, or do you modify this technique, Surena? Do you use the Dacron tapes?
I do. I tried to do it exactly like how he described it. I know you can use other fixation. I worry about fiber wire sometimes cutting out in these people, but I just use Dacron tapes.
What I also do is I augment it with sutures through the shaft, and I do a figure of 8 cerclage around the head and cuff to prevent even further rotation, kind of like what we do for proximal humerus fractures or reverses.
So, you know, she did great, never fell again. No, just kidding. So she fell 2 weeks, 2 falls in 2 weeks again post-op. And so now she's impaled her shaft like a shish kebab through the center of her humeral head.
That's beautiful. It's not going anywhere.
Stability.
Yeah. So, you know, she came in, wanted something done, and I told her that this was the best thing that could have happened. You know, there's no way now that this will come through her skin. You can see she's got a huge sulcus, which is a big deformity in somebody as small as she is. But, you know,
Dr. Horneff is a wonderful second opinion.
Yeah. And so, you know, we left her alone, and now she's a year and a half out, and her head is kind of recentered a little bit, and she's doing it, you know, as poorly as one could imagine.
But you know what? This X-ray, it's amazing to me when you follow some of these non-ops out, how they change and actually remodel and actually look fairly decent down the road.
Yeah. So, you know, I think we're at our time. So I'd like to thank the panel, you know, great discussion. I'd like to thank the course chairs, and I'll turn it back over to Sakib and the team. Thanks, guys.